A digital live audience. Well, thank you very much. I'm going to share my screen, and as I make my introductory comments, and again, thank you very much for the warm welcome and warm introduction. It's always a pleasure to be here at the Real Truth About Health. I think I want to commend you guys on doing yet another great job on putting on an excellent conference. I actually learned a lot by listening to the different speakers, and I want to encourage all the members to join and become a member and get a lot of this information. I think it's very important. But my task this afternoon here in Houston, is to address the issue of nutrition as an acute cardiac and medical intervention. Many of you will hear a number of excellent talks about the benefits of optimal nutrition. And when I say optimal nutrition, I think of plant-based nutrition as an optimal nutritional regimen. And I think most people would agree with that. And even people who promote, say, Mediterranean diet or promote keto diet or whatever, all of those alleged healthy diets or promoted diets all have plant foods. So the sine qua non of any healthy diet are plant foods. So that's my approach. However, the issue is when someone's acutely ill. So if someone has congestive heart failure that's advanced or coronary disease, or maybe they're hospitalized or in the ICU, can this nutritional approach work? And that's what I want to do. I want to discuss today. My context of work is in clinical practice. And as the bio discussed, I've implanted devices and treated patients with advanced heart disease for many years. And when I started working in this realm of plant-based nutrition, I had to start with patients who came in who've already had quadruple bypass and multiple stents after, and they were still very short of breath or being hospitalized. And so how do I apply and make this work in that setting? So we're going to, first of all, go over, create the context of what is chronic illness, both in the stable, so-called stable setting or the acute setting. And I want you to bear with me. I'm going to get a little bit technical in getting into some of these mechanisms. I think that's important, especially when I put it in the context of my comments later in the talk. And then we're going to do some case studies. I've put together 3 patients I've taken care of. And again, I want you to bear with me there because I'm going to go into some of the nuances of day-to-day management of sick patients in the hospital. However, I want to show you how applying nutrition, even in these advanced situations, can have a positive impact on the patient's well-being. So let's talk about chronic disease in general.
Dr. Montgomery, before you begin, sorry, this is John. Yeah, we see right now your presentation, and on the side we see a Zoom window.
Wait, hold on 1 second. Let me do this. Let me redo my share here. Is that better?
That's perfect. Thank you.
Wonderful. Thank you very much. I clicked the wrong selection there. Thank you very much for selecting that. You get into these talks, you don't know what you guys are seeing on the other side. So chronic disease, what is chronic disease? Well, basically, it's simply an illness or an ailment that's expected to last for more than a year. And we generally know what many of them are: heart disease, cancer, diabetes, lung disease, arthritis, chronic infections, and you can add more to this list. But these are ailments that people live with, and frequently they're on medications for them, or they're getting intermittent treatments, maybe surgeries or procedures, diagnostic procedures. So there's a chronic condition that you're having to quote unquote manage. But what underlies these chronic illnesses? There are 2 areas I want to focus on today: inflammation being one, oxidative stress will be the other. An abnormal microbiome could be a third. I won't talk about that very much today, but I want you to keep that in the back of your mind, because perhaps when I do this talk in the future, I'll probably talk more about your abnormal microbial ecosystem, which I think has a big impact on your overall health. But first and foremost, inflammation I like to equate to a biochemical fire. Chronic inflammation underscores just about every chronic illness that we know of. This slide doesn't show these words very large, but you got cancer here, neurological diseases, metabolic disorders, bone and joint diseases, autoimmune disease, cardiovascular disease. All of these are underscored by chronic inflammation. Essentially, it's driven by your immune system. It's in disarray. And so there's this chronic, ongoing triggering of cytokines at low levels that are causing immune mediators to go and cause damage. You got these little wars, these little inflammatory processes. I use the analogy of smoldering coals. If anyone's done any barbecuing, when I used to barbecue in the days I was a meat eater, you'd get your coals smoldering. They weren't flared up, but they were smoldering. So that's like your chronic inflammation. If you spray lighter fluid on it, then you get a fire, a flame, and that's a flare-up. And so an acute flare-up of someone who has, say, chronic obstructive lung disease, they have go into a COPD exacerbation. That's a flare-up from a chronic inflammatory process. Then inflammation flares up, they become acutely ill. The other major area is oxidative stress. These go hand in hand. Oxidative stress is, I like to akin to excess toxic chemicals. We may refer to them as reactive oxygen species or free radicals, but essentially, if you've ever seen an apple that's sliced and set on the counter and exposed to air, it starts to brown before your eyes almost. That's similar to a cell that degenerates over time due to oxidative stress. At the molecular level, you see free radicals, which are electron poor, and they're unstable in this electron poor state. So they then can cause cellular damage, DNA damage, but they can be stabilized by antioxidants. Sources of antioxidants are leafy green vegetables, which is why we recommend these things. Walking on the earth or grounding can have an antioxidant effect. So you have this unbalanced, excessive amount of free radicals or reactive oxygen species. It tilts the balance in favor of pro-oxidative molecules, and so that creates a net oxidative stress. And that can then lead to progressive deterioration and degeneration at the cellular and tissue level. So these are the foundations of chronic illness. And to the extent that these episodes become more imbalanced, an individual become more ill. Now, how does this work mechanistically from an inflammation standpoint as it deals with the cardiovascular system? Well, inflammation in the cardiac system potentiates a number of things. Inflammation contributes to what we call the pathogenesis and progression of heart failure. At the cellular level, you can have these pro-inflammatory cytokines. And many of you have heard of people going into cytokine storms, especially during the COVID epidemic. The people were dying, they go into cytokine storm. These cytokines are just molecular intermediaries. They're used by the immune system. They're signaling molecules, and they trigger more inflammatory activity. These pro-inflammatory cytokines, some that have been identified, IL-1 beta, TNF alpha. The names are not that important. I'm mentioning these because when I talk about some of the research we're planning to do later on, we're going to show that we're going to be looking at some of these pro-inflammatory cytokines. But these cytokines have been associated with abnormal heart function. Systolic function, dysfunction is when the heart doesn't contract normally, it doesn't squeeze normally, it doesn't eject blood normally. Diastolic dysfunction is when the heart doesn't relax normally, it doesn't allow it to feel, it doesn't feel normally. And so the amount of volume that's circulated, your own cardiac output is impaired if the filling and release of blood is abnormal. And so we can see at the biochemical level how these things can have an effect on the heart, and then it can affect you physiologically. So acute heart failure, we can think of it as a cytokine storm of the cardiovascular system. Now, if we talk about inflammation in the endothelium, these are the cells that line the blood vessels. Inflammation in the endothelium results in an impairment of nitric oxide generation. The impairment here releases what we call free reactive oxygen species. So you have increased oxidation associated with inflammation. So that's how these two can play hand in hand. Reduction nitric oxide bioavailability has two major effects. A molecule or cytoskeletal structural molecule called titin. It actually is the framework of the heart. It's normally elastic. And if this becomes impaired, overphosphorylated or underphosphorylated rather, it causes the heart to stiffen. So you can see how impaired inflammation can lead to reduction of nitric oxide, stiffening of the heart. Secondly, Impaired nitric oxide can lead to thickening of the heart muscle cells, further causing stiffening of the heart. So you can see how the biochemistry directly connects with the physiology. So people have come into my office and do an echocardiogram and say, oh, well, you have what's called diastolic dysfunction. You have a stiff heart. Well, why is that? What's the cause of that? There are biochemical causes related to inflammation, nitric oxide impairment that directly contributes to this. Endothelial inflammation causes a range of other types of effects. There are molecules that sits on the cell surface. We call some of them VCAM, elastin. These are the names are not that important, but these are cells that can, molecules that can signal whether the cell is inherently impaired or compromised by a pathogen. But this all leads to fibrosis or scarring of the heart. You can have impairment of microvascular, so that's poor blood flow. You can have impairment of stimulation of fibroblasts. All of these things lead to poor circulation, poor oxygen delivery, more ischemia, more inflammation, and more scarring at the heart. So what I'm trying to do is help you connect some of these biochemical abnormalities with some physiological changes. The last complex slide I'm going to deal with is the innate immune system. Again, we talked a lot. You may have heard a lot about the immune system as it relates to infections, coronavirus or bacterial infections. Now we're talking about the immune system as it relates to heart disease. So it shows how these diseases are very common and they have a common relationship. So it's not much different than someone has systemic autoimmune disease or someone has systemic inflammation from systemic heart disease due to inflammation as well. So activation of the innate immune system can again trigger these surface molecules. We call them pattern recognition receptors, but basically these are surface molecules. The common one on the heart is TLR4, but these are molecules that can determine, signal whether the cell is inherently damaged or whether the cell has been taken over by a pathogen. You have DAMPs or PAMPs. The names are not that important, but these are cell signaling molecules that signal damage to the cell. That triggers more inflammation, more inflammatory cells that come to the site. So you have this cascade of more and more inflammation that's being triggered. So chronic inflammation begets more chronic inflammation is the point we're showing here. And again, stresses such as ischemia. What is ischemia? Ischemia is inadequate blood flow or oxygen delivery to tissue. So if you have poor coronary flow, if you have arteries or endothelial cells that are impaired, and so the arteries don't dilate and deliver oxygen, so you have less oxygen delivery, more ischemia, perpetuates more inflammation. So there's this negative cascade of events that happen that causes more inflammation, more oxidative stress, which then triggers more ischemia and the like. So oxidative stress, let's go over this real quick. As I said, it's an imbalance between molecules that are considered, say, free radicals or reactive oxygen species. They're unbalanced with antioxidants. So what effects does this have on the heart? Well, it can have electrical effects on the heart. So excuse the complexity here, but essentially reactive oxygen species increases the amount of influx of calcium inside the cells. This results in arrhythmias such as atrial fibrillation or other atrial arrhythmias. It can also cause sodium channel abnormalities, which can result in ventricular arrhythmias. So people that you may know who have atrial fibrillation, who are on blood thinners or other medications, well, the mechanism here can be triggered by excess oxidative stress. And so if you do things to reduce oxidative stress, you can then do things to reduce these arrhythmias. And we're going to talk about these mechanisms that we're going to look at in some of our studies and also in some of the clinical patients that we're going to discuss. There's also other molecules, ryanodine receptor 2, again, more calcium influx. This can lead to contractile dysfunction. The ability of the heart muscle to contract or relax can be impaired by excess calcium overload inside the cell. Furthermore, you can have mitochondria damage, which is secondary to ischemia, which then mitochondria releases more reactive oxygen species. Also, mitochondria are the energy cells for the body, so ATP production can be impaired. So some of these ATP-dependent biochemical reactions can be impaired. So increased reactive oxygen species can also directly lead to increased fibrosis. So as they said, a picture's worth 1,000 words. In summary of what I just, talked to you about, number one, electrical disorders can come about through increased oxidative stress. Number two, you can have abnormalities in the sarcoplasmic reticulum due to increased calcium inside the cells that can affect contractile function, systolic or diastolic. Three, you can have mitochondrial dysfunction related to reactive oxygen species. This can impair mitochondrial function, i.e. reduce ATP production efficiency, but also cause more reactive oxygen species release. And number four, direct fibrosis development as a result of oxidative stress. So I just wanted to give you the background from a mechanistic standpoint, because we're going to discuss how do you connect food with improved cardiac function. And I want to just give you a background because we're going to talk about some of these mechanisms. We talk about some of the research that we have done and some of the research that we're planning. So plant-based nutrition. What are the general benefits? I'm not going to spend a lot of time on this. As I alluded to earlier, many of my colleagues will talk about the general benefits of plant-based nutrition. I think a plant-based diet is a superior diet, but which plant-based diet is going to be an important one to differentiate. I shared just this one article with you where they looked at a low-carb diet from plant versus a low-carb diet from animal sources. And this is in patients who had prior myocardial infarction. So among people who survived myocardial infarction, greater adherence to a low-carb diet and high animal sources of fat and protein was associated with a higher all-cause and cardiovascular mortality after MI. So is one long study. There are other studies that show survival benefit favoring plant-based diets, but I just want to lay that background in my discussion, because as I go forward, we talk about optimal nutrition. We're talking about a plant-based diet. So it's not a matter of whether you should eat a plant-based diet or not, in my opinion. It's a matter of which plant-based diet should you eat and the details there. And that's what we're going to get to when we talk about the food prescription. So nutrition for the acutely ill, can nutrition have an impact? So as I alluded to before, as the other study alluded to, it's great to say, eat a healthy diet and over time you'll be healthier. You can exercise, et cetera. And I think we inherently know this, especially in people who are out and about. But what about someone who's having a heart attack, or someone who's in the hospital, they're in the ICU, or someone who is acutely ill in the office? Can this nutrition have an impact in a matter of hours, days, or weeks? And that's what we want to learn. And what I want to do is I want to share some clinical case presentations and walk you through how I use this in my practice and my patients who are in the ICU, the CCU, who are in our office, who are acutely ill. And I want to walk you through how this process goes. So let's go start with our first case. This is a patient with cardiac amyloidosis. Cardiac amyloidosis is what we call an infiltrative heart disease. It consists of usually a genetically predisposed condition where you're making excessive abnormal proteins, sometimes light chains and other proteins that malform and can infiltrate different organ systems, the heart being one of them. So this patient is a 62-year-old man who we had been treating for some time, and he began having some problems with some tachycardia, had some arrhythmia. His ejection fraction on echo was about 25 to 30%. On the previous echo, he had a history of pulmonary emboli. Even prior to coming to our practice, he had had pulmonary emboli and deep venous thrombosis. He had been on blood thinners before and had some issues with different ones. Had a history of hypertension. We had suspected cardiac amyloidosis prior to this hospitalization that I'm going to discuss, but it had not been confirmed until subsequent to this time. So I just put this in the note, suspected amyloid cardiomyopathy, but it was confirmed by previous studies. What I want to do right now is I'm going to put a pause on my screen share, and I'm going to bring up an echocardiogram to give you an idea of what his heart looked like. Hold on one second. This is where we test my technical skills in the program. And okay, All right. So y'all let me know if you see a diagram. Oh, hold on one second here. This is not his heart. Hold on. Okay. Y'all see heart moving? Can somebody just let me know they see a heart moving? I'm going to go on with the discussion. So this, I'm not going to show too many details. This is the left ventricle, and this is the walls. This is very thick. Now, I know many of you are not accustomed to seeing these ultrasounds of the heart. Some of you are. This is the left atrium. You have the aortic root here, the right ventricle there, and there's a little bit of fluid back there, a little fluid around the posterior part of the heart. And this heart is enlarged, it's very thick, and it's not moving very well. I'm just going to go through different parts of it. Here's an M mode. This should show like a sine wave, okay? And it's just barely, it's almost straight. It should go here and here to show contraction, but it's not showing a lot of contraction at this particular time. Now, the amount of contraction can improve or worsen. Here's a donut part of the heart. You see, this part is thickening here, but this part is not moving very much. Here's the right ventricle, the left ventricle. See how thick this wall is? Very thick. That's hypertrophic. It's not hypertrophic cardiomyopathy, but it's hypertrophy due to the infiltration of the amyloid in the heart. You got fluid around the heart. That's what this little black area around here is. There's some fluid in the front part of the heart there. I'm just going to show you a few images there. So I'm going to stop my screen there, and I'm going to minimize this. Hold on one second. Now, so basically what I want to do is continue with his case discussion. So there's a picture of the patient's heart. And so he had several months of what we call claudication, of pain in the left leg. He had pain in both legs, but much more severe in the left. And it just got progressively worse. And he presented to our office with worsening pain. And he couldn't walk about 10 yards. So we did an ultrasound, a Doppler study in the office, and found that one of his arteries on the left was occluded. And we didn't see pulses in the left leg. So this constituted an emergency to admit the patient to the hospital. So we did admit him. He underwent some medication adjustments and diuretics in the weeks leading up to this time, but he had an occlusion to the leg. We noticed heart rate upon admission was in the 100s. The rhythm was an atrial flutter rhythm or atrial tachycardia. They cannot get Dopplerable pulses in the left lower extremity, but they were able to get them on the right. His kidney function was a little bit abnormal from baseline. His potassium was a bit lower. His B-natriuretic peptide was in the 500s. I'll discuss that a little bit later. So on the 22nd, he was admitted to the IMU, started on intravenous heparin. I called my interventional cardiology colleagues. Peripheral angiogram was done, and was found to have multiple acute thrombi and, of course, an occlusion in the SFA, the superficial femoral artery. Based on that angiogram, we decided to call the surgeons, and he was sent for an emergency surgical thrombectomy. What they did is went in, surgically removed the thrombus or the clot. They saw some vessels that needed to be bypassed from the femoral to the tibial artery, with more clot being removed. So it was a pretty extensive surgery. Lost about 1 liter of blood, had to have some crystalloid and albumin given. He wasn't transfused immediately at that time. And I'm going to walk through some of the nuances of the hospitalization, because I think some of this is important, because the thing to take from this, and I'll walk you through it, I don't want to overwhelm you with the details, but I want you to get a feel for the level of complexity and the number of problems that we're dealing with when we have a patient who's acutely ill. Many of you who are pretty healthy may not have been, acutely ill before, may not have had a loved one, but these are some of the things, at least this is from the backside of the scenes, in terms of how you're dealing with it, what you're doing with an acutely ill patient. So his kidney function, as I said at the beginning, was abnormal from baseline. We got a nephrologist involved. There was transient loss in some of the pulses in his feet. They got an emergent CT angiogram. Now, again, the CT angiogram, they use contrast. Now, here's somebody with compromised kidneys. You give them contrast, which can further compromise the kidneys, but you're doing it emergently because there's a concern about the loss of his pulse. Now, again, when someone loses a pulse and loses blood flow, that constitutes an emergency because they could potentially lose that extremity. So you're doing a lot of things for the patient that could potentially harm him in another way, but you're sort of doing it in an urgent manner. So he was able to move the foot more after he got more pain pills. The pulse did come back magically, however, and it could have been spasm in the artery. Who knows? So the surgeons were managing him. Of course, we were managing him on the cardiovascular side. He was given a unit of packed red blood cells because blood count was low. You try to minimize the amount of blood you transfuse on these patients, but I don't like a low blood count on somebody with some peripheral vascular or any coronary vascular compromise because they need the red cell carrying capacity. So hemoglobin of 7.8 in a patient like him with a resting heart rate in the 100s was too low. So we gave him some blood. Later on, he got more blood. Now, things started becoming more problematic on the next day. His creatinine continued to get up, go worse. And I'm going to show you graphs of these labs at the end of this discussion, at the end of this section of the presentation. His lactic acid. So basically, we measure lactic acid, see how much acid is building up in the blood. The more acid's building up in the blood, that tells me the less perfusion. So if you're not getting oxygen delivery to your feet, your toes, then you develop acid buildup because you're not able to clear acid and remove the acids buildup due to normal metabolic activities. And so lactic acid buildup, it was fluctuating, it was up and down, but there was something that was concerning us because we were concerned about blood flow. His hemoglobin did come up after the packed red blood cells transfusion. He was getting more pain medications, even more blood because he started bleeding from the wound. We were trying to give him heparin to anticoagulate him, but that potentiated more bleeding. Again, you're doing one thing to help him in one way that harms him in another way. And so you have to back off. And so we had to hold off on the heparin. He became hypotensive. We started on norepinephrine. Again, starting norepinephrine makes the heart rate worse because he has an arrhythmia. It also can constrict blood vessels, but we had to get the blood pressure up. So we're dealing with this delicate balance of things. They tried to stitch the bleeding closed, but that didn't work. And one Saturday morning, I walked in and the patient had numbness and no pulses in the leg that they had operated on, and it was swollen. And that was the immediate diagnosis we made of compartment syndrome. So I called the surgeon. They jumped right on it. He was a little bit agitated. There were a number of other things going on. So they took him back to the OR to open up that wound, to release some of the bleeding. I called my colleague to evaluate him for EP. I'm an electrophysiologist, but I actually have her do all my procedures now because I'm focused more on nutrition and wellness. So she agreed to take him for an atrial flutter ablation the next day. The surgical team talked about calling advanced heart failure, but I felt it wasn't necessary because I think we just need to get his heart rate and rhythm under control. The surgeons took him back, evacuated the blood, and things improved. So he had the wound wash out. There was a wound vac placed to drain that wound area, to keep it from swelling. He went to the cath lab and we got rid of the atrial flutter. There was an atrial flutter ablation. This is going to deem to be very important as I go through the summary. And so on the 27th, we started the nutritional detox. Now, all of this stuff going on, you got surgery and imaging studies and procedures and all. And I had discussed detoxing earlier. There was some back and forth between the nephrologist and I had to let her know that I'm the attending physician. And, we had a little bit of fighting there, but, everything got straight and we were all friends. But the long story short, we had tried to start the detox a day or two earlier. There was some confusion. It was started without interruption on the 27th. That's an important thing to know. So you had the atrial flutter ablated here. The nutritional detox was started here. What do I mean by detox? And I'll show you some images of the food, but we put them on raw fruits and vegetables only. We had superfoods of blue-green algae. We put a super green powder added to smoothies. Who have salads and wraps. He drank coconut water and a number of other things. So the creatinine at this time was almost 5. The nephrologist was concerned. She and I agreed that we wouldn't start dialysis right away. We would hydrate, get his hemodynamics under control, because I think most of this was due to the heart failure with the arrhythmia. So he received more packed red blood cells and more diuretic. So after about 24 hours of this, things started to turn around. Okay, he did have a urinary tract infection they picked up on. They addressed that. An echo was done. His heart was beating at less than 20%. And you saw an image similar to the echo that we did here. Severe thickening of the heart, no blood clots inside the cardiac chambers because we had to stop the heparin because that was important to know that there were no blood clots there. A little bit of infusion. By 2 to 3 days, 3 days after he had the ablation and started the detox, there was still some edema, but he was okay to get up out of bed. We held his beta blocker medication because of the transient hypotension he had, but his blood pressure was holding on its own without the beta blocker therapy. And his heart rate actually was under control after the ablation. So he was stable to leave the ICU and went to IMU. So he had recovered enough to go to the step-down unit. He continued to do well by the first of the month. This is just a summary of the things that happened over the course of the last few days. So we're about 4 to 5 days after the ablation of the arrhythmia and also improvement of his diet with the detox. So on day 4, which was about 8 days after, he was able to go home. So what happened in this hospital course? I went through a lot of nuance with you on this patient, but I want to give you some data to show. If we look at his creatinine, we saw the creatinine went up, and this is a sign of abnormal kidney function. Glomerular filtration rate is kidney filtration rate. It went down. This is a time when he was acutely ill after surgery. He went into surgery on the 24th, and we were dealing with these problems of bleeding and low blood pressure, and all these things contributed to the low kidney function, which already was low when he came in. And so it got worse. Also, we gave him contrast. The nutritional detox started between these 2 days. The ablation started here. And after that, his kidney function started to improve with improved cardiac function. The lactic acid built up. It then dropped. And after here was normal. Liver congestion also peaked when you had poor cardiac function. So all of these things peaked when he was acutely ill. And we also see the white blood count is a sign of inflammation. So increased inflammation, decreased cardiac output, increased inflammation here. And you see the inflammation going down. But notice the inflammation didn't even normalize even when he went home because he still had an open wound that we were managing. Albumin level drops because of increased inflammation. So in summary on this patient, to put all this together, I know I went through some nuances with you, but what were the key reasons for this patient's decompensation? Well, one, he was on a plant-based diet. This patient was followed by us, followed by my PA. However, he was eating a fair amount of cooked foods. Maybe some might have been microwave, I'm not sure. But he did take some kind of an over-the-counter herbal tea I didn't find out about until later. And he went into this atrial arrhythmia. This really led to a compromise of his cardiac function. This also probably contributed to the embolization and occlusion of the artery in the lower extremity. And the need for surgical and intervention also led to further compromise. Key reasons to recovery. Well, we got to him urgently. So the surgery and revascularization was important because that took away the ischemia in his leg, which was triggering more oxidative stress, more inflammation. But also we ablated the arrhythmia, which compromises cardiac function. But also key to this was this nutritional detox. We put him on raw fruits and vegetables. Now, one thing I didn't point out is that his medication list was very, very minimal. And so we were able to control his heart rate and blood pressure with just nutrition without him being on 5 or 10 medications. He was already on a plant-based diet coming in. That was also to his advantage. And all we did is just dialed it up, made it more refined and more anti-inflammatory. So let me go on to case 2. This is a patient with severe mitral valve disease. And her hospitalization is a little bit less complex. She's a 66-year-old lady with heart failure. And her predominant problem was severe mitral valve regurgitation or leaky mitral valve. She had what's called an intraventricular conduction abnormality, which also can worsen heart failure symptoms. So we had been managing her as an outpatient. She was also on a plant-based diet, but she was eating a lot of processed plant-based food. So while I talk about a plant-based diet being, I think, the superior diet, it's important in terms of how you're applying that, how you're preparing the food, where you're getting the food from. So any vegan diet, all vegan diets are not created equal. As she was on a vegan diet, now she may have approached as vegetarian, may have had some eggs from time to time, but the long story short, despite having a relatively healthier diet, her condition progressed because of its advanced nature. Let me pause and show you her echo real quick. Okay, I'm just going to go through and show you the amount of leaking. This is the left ventricle. This is the right ventricle. See this left atrium. You may remember the other picture. This chamber here was much smaller than what you're seeing here. This left atrium is huge. It's bigger than the left ventricle. And so that's abnormal, just to let you know that. I'm just going to go through and show you a couple of images. You see all of this color, this mosaic color going in. This is blood leaking back in the left atrium. So the severe leakage of blood back to the left atrium, the blood's supposed to go from the left atrium to the left ventricle. A lot of blood's going the opposite way. It's going the wrong direction. So that chamber is very large, and that's why you see the chamber be very large. I'll just go through a few other images here. You can see a short chamber. Let me just show you. So again, more regurgitation there. Tricuspid valves regurgitating. I'm going to try to show. This is a 4-chamber, left ventricle, left atrium, right ventricle up there, right atrium. And you see here, the left ventricle, see how much blood's going back. There's a little bit of leaking going back here, but it's severe. It's going all the way back and just filling up that chamber. That was the major problem. And she had some restrictive impairment. So I'll stop my screen there. So now that you're all experts in reading echoes, we will go back to the presentation. But I want to give you a glimpse of what we're dealing with in terms of her cardiac condition. So this patient progressively got worse. We admitted to the hospital and started on intravenous diuretics. And the plan was to have her stabilize in the hospital. I was going to call my colleagues in interventional cardiology, structural heart, to look at possibly doing what's called a mitral clip to repair that mitral valve in a minimally invasive way. We wouldn't have to open the chest. She wasn't a candidate for that. She had a history of lupus and was probably in a lupus flare that may have been contributing to some of these symptoms. She had episodes of worsening dysrhythmias while in the hospital, worsening heart failure, requiring to be transferred to the CCU. Now, as I said, she was having some other symptoms of a lupus flare, so I think the lupus flare was contributing to this. So you had systemic inflammation from one other etiology, if you will, that was contributing to her overall ischemic inflammatory milieu. This inflammatory milieu led to increased oxidative stress, led to more arrhythmias. Remember, we talked about the mechanism. More inflammation, more reactive oxygen species leads to more calcium influx in the cells, more arrhythmias, atrial arrhythmias and the like. That's what was going on with her. So we did consult some of my colleagues. We did get the arrhythmia under control with medication. She was in the CCU. And so the first team call was the structural heart team. We wanted to look at the mitral valve to see if we can get that mitral valve repaired. They deemed that the patient was too sick to undergo this procedure and so wouldn't benefit significantly. I called my electrophysiology consultant to see if she would benefit from biventricular pacing to improve her cardiac output. She probably saw the structural heart team's note and said, well, the patient was deemed too sick to undergo this procedure. So to make a long story short, we had to call a palliative medicine team. They would consult to evaluate the patient. We got her on inpatient hospice. She was on vitamin C, diuretics, hydroxychloroquine for her lupus, and she was put on a milrinone infusion for the heart failure. She was on some other medications, Sotalol for the arrhythmia. And we were going to discharge her to a hospice facility. And we were told that they would take the milrinone infusion. However, within 24 hours of being discharged, they were not able to give the milrinone. And so the team was called back because of this, the palliative medicine team, and they recommend to the patient be discontinued from milrinone in the hospital. A lot of patients will die in the hospital. So I went and saw the patient in her room. One day she was crying and said, look, they're going to stop the medicine. And they told me I can order my last meal, have my family come and see me. So I said, well, let's try this. And I talked to the hospital case manager. I said, look, give us 7 days and we'll try one more thing. And so we tried on a nutritional detox regimen for a 7-day period. And over that time period, and I put on mostly smoothies with super greens like blue-green algae and other types of things. She did have a salad, but I had on mostly smoothies because I didn't want to have her on solid foods because of heart failure. She had some edema, probably intestinal edema, and probably would not absorb these solids very well. So after 7 days, we were able to wean off all of her medication except for one diuretic, Bumex or bromodenide, 0.5 milligram only on an as-needed basis if she can weigh 2 pounds. So, and we'll take a look at her clinical data. Now, this is a little bit confusing because it went up and down. Her kidney function went up and down as her cardiac function got worse. So when we stabilized her heart rate and her cardiac function, the renal function, perfusion got better. The creatinine came down. The creatinine went up when she went into arrhythmias and bounced around. This colored bar here shows when we start the detox and the kidney function sort of stabilized. And again, we were weaning her off of milrinone, which is a medicine that improved the heart function here. So her kidney function and therefore heart function stabilized. The glomerular filtration rate, same thing here. It goes up when the kidney function and heart function goes up and goes down, like when she's in arrhythmias and renal perfusion is bad, up and down until we stabilize things. After the detox, it came up and stabilized at a normal rate. Notice that even though it's here, it's not as high as it was here, but she was on milrinone, a medication to actually, improve contractility, where we had weaned her off the milrinone as well as other medication. Lactic acid bounced around and stabilized, and we got some outpatient lactic acid levels that were normal after she had detox and had stabilized that area. Liver congestion. So the liver becomes inflamed when inflammation is built up. Could that be the lupus flare causing it to be inflamed? Possibly. Could it be congestive function or congestion from heart failure? Possibly. But either way, as we got a cardiac condition improved, this came down, and then the detox helped her stay down. ALT, same thing. It's another liver enzyme. White blood counts. Interesting enough, after we detoxed, the white blood count went up before it came down. And you can often see when people detox, they can have a flare up before it calms down. But also, this is a sign that inflammation came down. The key thing with this patient is this: the medication list upon the initial discharge, when she went to hospice, she had 6 medications, one of critical, milrinone, hydroxychloroquine to keep inflammation down from lupus, diuretics, etc. After detox, she only went on 1 medication as needed. And I think the reducing the medication is important. Some of these drugs are metabolized through the kidney, the liver. And so the fewer medications, hepatically metabolized, the less stress on the organs such as kidney and liver, the better the person does overall. So the nutritional detox allowed us to wean her from medications and keep her hemodynamically stable. And not only did she get discharged, she went to home with home hospice and was able to go out and have a better quality of life. Number of medication went from 6 to 1. And I think that was a significant improvement. So in summary, key reason for the patient decompensation, I think she had a suboptimal plant-based diet. I'll talk about that a little bit in our discussion or Q&A session. She had severe mitral valve insufficiency. That was a main problem, but the atrial arrhythmias made it worse. But I think her lupus flare was probably feeding into this. And so making all of these things worse. These things have a negative cascade as they feed into, one feeds into the other. Cardiac conduction abnormality, the intraventricular conduction abnormality, I think, was also contributing to her problem. And again, the systemic inflammatory flare of the lupus, as I alluded to. Key reason for recovery, I think the nutritional detox was more central in her case than the other patient because we had nothing else. I mean, this patient was, left to die on hospice. And because of the detox, we were able to wean the medication. I think medication weaning in patients is very, very important. The fewer medications the patients are on, the better off they do because less stress of the organs and our organs are already compromised. So the less we're stressing the organs, the better off. The third and final case is a little bit less complex than the earlier two, but this is a gentleman, 76-year-old man with a history of diabetes, had prior stroke, DVT, and was currently on anticoagulation. He had a chemical stress test in 2019, which showed some mild ischemia, if I remember correctly. But he's presented to an outside hospital with some chest discomfort and was a little bit nauseated without vomiting. EKG showed some acute injury patterns in some of the leads. I won't bore you with the details of that. But nevertheless, he was seen by a cardiologist and taken to the cath lab emergently based on the symptoms and the EKG abnormalities. What happened there was the cath showed diffuse multivessel coronary disease. The cardiologist felt that he wasn't a candidate for PCI or stent placement, so he recommended urgent coronary bypass surgery. The family, they did contact the surgeon at another hospital that I don't go to, but the family reached out to me through my answering service, and they wanted to come to the hospital I work at. So after a series of phone calls and working through transfers, initially we weren't able to get him there. We were finally able to get him to our hospital. So when I saw him that night and the next morning, again, a 76-year-old man, multivessel CAD, and the question was, does he need cabbage now? I talked to my surgical colleague. We both agreed to let him wait for the better part of a week on a heparin drip, and as a surgeon like to say, let him cool off, stabilize clinically and hemodynamically. We did get one of our interventional cardiologists to take a look at the films, and he felt that PCI or stent was not, patient not a candidate for this. He'd be better off for cabbage. Unfortunately, the patient, he didn't want to wait around the hospital. He left against medical advice after trying to talk him into staying. So he left within the first 24 hours. However, he got home, was there for maybe 12 hours, decompensated even more, came back to the emergency room, blood pressure was low, and he was seen by the surgeon and the interventional cardiologist, and both were saying he was too sick to operate on. So his hospital course, when he came in, he had a troponin level. Troponin is a molecule we measure to determine if there's injury to the heart muscle. And so he had an elevated troponin at the other hospital. It was elevated when he came to our hospital. We started this detox somewhere between the 1st and the 2nd of June. That's why I highlighted both of these. But the troponin was coming down on its own because he was just, recovering from an MI. B-natriuretic peptide, he came in at 300, and we started hydrating him, and the like, it went up. B-natriuretic peptide is a molecule that's a sign of heart failure. Oftentimes the heart muscles are tense with fluid. You can release more BNP. People with heart failure tend to have a BNP that should be elevated because that's their normal physiology. So when he was at 304, he was probably dehydrated, and other labs showed the same. His creatinine was elevated early on with more hydration. That improved throughout his hospital course. And again, his GFR was low. I think this is more hydration in addition to low cardiac output. With the detox, he was drinking raw smoothies. He was getting salads, some fruit, and his hydration picked up with that as well. We were able to wean some medications, not a lot. He had a high lactic acid level, which did come down some during the course. And his inflammation, the reason I show white count is when a white count comes from like mid-normal to high or high normal, that's a sign of increased inflammation. And this, although it came down, his inflammation did not go totally to normal even upon discharge. And albumin drops as so if the white count goes up, inflammation goes up, albumin drops. So this is not because he's on a raw detox diet. This is because inflammation, albumin leaks. And liver congestion, which was high, it also subsided as the patient recovered. So in summary for this patient, the reason for his decompensation, this patient was not on a plant-based diet. I've been seeing him for a number of years. He's kind of old, stubborn, cantankerous gentleman. He had advanced atherosclerotic disease, had a hypercoagulable state with prior DVT and PE, pretty stubborn and non-compliant. He had started on a nutritional detox. Being in the hospital bed rest can help a lot of people, and I think that helped him. When he went home, he probably tried to move about, and it wasn't, good for him. And in fact, we did do some medication weaning, not a lot in him, but we were able to wean some of his medication. But I think the nutritional detox was the main trigger for his recovery, in addition to bed rest and partial medication weaning. So here's a patient with advanced coronary disease who was in the throes of a heart attack, but he was too sick to receive what's considered the best treatment for a heart attack in emergency cases, which would either be an emergency stent or emergency bypass surgery. He was only left for a nutritional detox. So how do we know that this is working? I mean, could this just be 3 patients, Dr. Montgomery, you're just presenting, who just happened to do well, and you just gave them some smoothies at the same time they would have done well without the smoothies? And I think you can make that argument. And that's why I think we need to look at some of the data that we've shown, we've had before. And we've looked at in our previous publications, what are some of the effects, anthropomorphic and hemodynamic effects of food? We looked at a series of patients, and this is in an outpatient setting, where we put on a defined plant-based diet, similar to the diet I've treated these patients with. And we look at things like, weight, BMI, systolic, diastolic blood pressure, medication weaning. And what we see, this is a busy slide, but at weight, at baseline on average, the weight is 108 kilograms, goes down to 107. These are all statistically significant difference from week to week. So we see the weight, the BMI goes down. That's no surprise to you. We also see systolic and diastolic blood pressure go down, which also should not be a surprise. Heart rate also goes down. And we've seen this before over the years. And we do this at the same time we wean medications. This is an important slide because it shows that you can get favorable hemodynamic effects with just food alone, while at the same time removing medications. This is data from a series of patients with congestive heart failure. We see that the stroke volume, the amount of blood that the heart contracts with each beat, increases. That increases the circulation. We see the amount of thickening of the heart muscle, the LV mass. So the heart, which is enlarged, it regresses with just diet. We also see that the stroke volume, again, the amount, this is the ejection fraction, I'm sorry, the percentage of blood that's ejected, and the stroke volume, the amount of volume that's ejected with each contraction, all goes up. And the cardiac output, which is total summary of circulation, goes up. So we know that food has a positive effect on patients with heart failure. I've highlighted some of the anti-inflammatory and biochemical results. C-reactive protein is a molecule that we use to measure inflammation. At baseline to final, we see about a 30% reduction in inflammation in just 4 weeks, very statistically significant. IL-6, we talked about these cytokines is one particular one that we measure, 23% reduction. We've seen this before. Plaque-2, which is a metabolic mediator, behaves in some ways like a reactive oxygen species associated with inflammatory molecules as well, 16% reduction. Fibrinogen, acute phase reactant, increased fibrinogen can predispose to clotting, a reduction by almost 6%. And white count, as well as also other types of sub-white count molecules, reduced by 22%, all in 4 weeks. This is just with nutrition alone. Metabolic changes, hemoglobin A1C reduces, as you see, CRP goes down, insulin level production goes down, triglyceride lipids. So there are positive biochemical effects that we've already shown using nutrition alone. So we know mechanistically these things are going on. And to what extent they're happening in these patients who are acutely ill, more future investigations are needed. So moving forward, as I kind of close out this talk, I want to talk about our global objective. The study of the future study we're planning, we're actually in the process of launching the study now. But we're going to look at the defined plant-based diet, and we're going to compare it to Mediterranean diet. We're going to look at the effects of these two diets on patients with known heart disease. But we're also going to look at not only the clinical effects, but in the very same patient, we're going to collect blood and look at the biochemistry of what's going on in these patients. At the same time, we're looking at the physiology and the clinical findings. We're going to randomize the study. They're going to have food provided by 2 nutrition centers. And we're going to try to correlate the clinical effects of the diets with the biochemical and molecular effects. The things we're going to measure are usual blood pressure, weight, echo, EKG stress test, cardiac monitoring. We're going to look for cardiac arrhythmias at baseline plus after. We're going to look at lipids, C-reactive proteins, a lot of biomarkers that we normally look at, as well as questionnaires. And we're going to look at biochemical assessment. So we're collaborating with the university where we can look at TNF alpha, IL-16, IL-1 beta, many of these cytokines that we talked about earlier, nitric oxide, polyphenols. We're also going to analyze the macro and micronutrients of the food they're eating. So we're going to look at the biochemistry of the patient, their blood, and we're going to look at the biochemistry of the food that they're eating. We're also going to look at other things such as monocyte, leukocyte isolation analyses, endothelial nitric oxide. We're going to look at gene expression of cell hypertrophy, and we're going to look at sarcoplasmic reticulum stress. So there are a lot of technical terms here, and I'm not trying to bore you to death, but what I want to do is give you insight to the fact that we're going to be looking at from the clinical aspects of what is happening to these patients, and at the very same time, what's happening at the cells. Rarely do you see a study. You see lots of studies where we'll put patients on a plant-based diet and the blood pressure gets better, the blood sugar goes better. Well, what's the mechanism? What's happening? And we're going to look at that. And this is a study that's rarely ever done in medicine. In fact, we looked in the medical literature, haven't seen any study where they looked at the biochemistry at the same time they looked at the clinical effects. Usually these biochemical details are done in animal studies, or they may be done in isolated human studies, but you're not looking at the clinical effects at the same time. So it's a really important study that we're looking at. And I think it's going to give us insight as to exactly what's happening with these patients. A quick word about the food. I won't belabor it. Picture's worth 1,000 words. This is an example of some of the food that people eat on a raw detox regimen. You have the nori rolls, you have the Hulk burger, beet burger, and that's a raw pizza with salads. We have dehydrated onion rings with a Hulk burger there. We use super greens in their smoothies and a blue-green algae also in their smoothies. This is a better than tuna sandwich. So this is just a snapshot of the types of foods they consume in this type of a regimen. So what are my final thoughts? Why do we do this? What's the purpose of all of this? First of all, the benefits of leading a healthy lifestyle, pretty much universally accepted. Diet and exercise, we know that. The benefits of a plant-based diet are generally universally accepted. I know that some people promote other diets, but plant foods are part of those diets. But I think plant foods, I think universally accept as healthy foods, and plant-based diet, the data I think is very strong that are superior to other diets that are non-plant-based. However, when you get to plant-based diet, how do you apply this, this whole lifestyle medicine in clinical medicine? A patient's sick, they're on 20 medication, they're short of breath, they're swollen. How do you supply it? So what foods should you consume in what circumstances? Some people say, no fruits, high fruits, low fruits, et cetera. Raw versus cooked versus uncooked. So, what are the answers? And then we're going to get into some of these things. We'll look at the biochemistry of what happens in the sickest patients first, and then we'll work our way back. From where should you get the foods? I mean, is a salad from a fast food restaurant as good as any other salad? How should food be prepared? Should it be microwave, steamed, dehydrated, fried, all the above? So there are a lot of questions in terms of how you apply nutritional lifestyle. And a lot of these questions need to be answered, and a lot of them needs to be answered in a clinical setting. So our vision is to develop a nutritional interventional process or processes with scientific validation that will contribute to a greater understanding in this area of the application of optimal nutritional lifestyle in the clinical setting. Thank you very much. I know that was a very, very technical and clinically detailed presentation, more so than I normally give, but I thought it was necessary to help you out with that and give you some insight into some of the complexities, but I'm willing to answer any questions related to that. So I'll stop my screen share and I'll turn over the mic to our moderator.
And thank you for that, Dr. Montgomery. In fact, thank you for really a very thorough presentation. We really, really appreciate that. Really amazing. And that said, I just want to make sure everybody understands where to go if they want to get your book or how to reach out to you directly, if you could share more about that.
Yeah, so if you go to our website, montgomeryhart.com, you can see under shopping, go to the bookstore. You can also just Google the food prescription for better health. You can get it on Amazon, so you can get it through our website or get it directly on Amazon. You can go to montgomeryheart.com/journey. We have a private online program where we help counsel and coach patients as a private community, if you will. And many individuals, we have patients from all over the United States, and some of them see us as patients, some follow some wellness programs. But montgomeryheart.com/journey, you can then get information about our online community, and there you'll get information about many of our programs, detox programs, and the like.
Excellent. Thank you very, very much for that. And thank you also for being ready to take some questions. Want to make sure everybody knows how we go about that here at The Real Truth About Health. A lot of folks do, and just in case you don't, we ask people that have a question to go ahead and raise their hand. And so some people are starting to do that now. That's great. For those of you that don't know how to raise your virtual hand here at The Real Truth About Health, what we do is we have you go down to the bottom of your Zoom screen or window, and you'll see your different tabs there. You click on the tab that says reactions. And when you click on your reactions tab, you'll see a few emojis pop up, and one of them is a function that's the raise hand function. You click on that, we will see your raised hand. We're going to take questions from people in the order in which they come. And when it's your time, I'll go ahead and call on your first name, and I'll unmute you, and you'll be all set to go. So with that, Dr. Montgomery, if you're ready.
I'm ready.
Awesome. Thank you. And so our first question is coming in from Crystal. Hi again, Crystal. Welcome.
Hello, Dr. Montgomery. You are just awesome. I follow you online. I try to listen to every presentation and talk that you have. So it's tremendous work that you do. It's tremendous work that you do, and I appreciate it. I wanted to ask if you. You're welcome. I wanted to ask if you do virtual visits online, or do you have to be a resident of the state of Texas?
That's a good question. So the answer is yes, we do. However, the state of Texas require that you have at least one inpatient visit. So people see us, they'll come, fly to Houston, see us once. Then once you've established that, you're a patient. And then we have a digital health program. In fact, even people who live in Houston, whether you're across the street or across town or wherever, we do digital visits with patients from anywhere and everywhere. But the answer is yes. If you, as a new patient, we ask you to come in for one visit in person and then establish that, and then we follow you remotely from that point on.
Okay. All right. Thank you very much.
Thank you. Thanks for the question.
Thanks very much for that, Dr. Montgomery. And up next, we have Stephanie. Welcome, Stephanie.
Hi, Dr. Montgomery. Thank you so much for taking the time to do this. Love your work.
Thank
you.
So
I'm someone who has a high blood pressure and tachycardia. I'm trying to heal with a plant-based diet, but I've only been doing it since January. So I'm kind of like still in the throes of trying to reverse some of my conditions nutritionally. Mm-hmm. And in a couple of weeks, I am donating bone marrow to my father through apheresis. Mm-hmm. And I'm just wondering, being a heart patient, is there anything that I should do before and or after recovery to make it better? Because I'm a little nervous about them doing so much with my blood and possible clotting and different stuff. So, anything you can help me with on that would be greatly appreciated.
Well, no, thank you for the question. First, you want to make sure, and typically they have pretty good screening processes before they let you be a donor for anything. I mean, even people that are just doing a simple blood donation undergo a basic screening process. So just make sure you meet with your primary care doctor and they're aware of it and go through a screening process, because they want to look at your medications. There's certain things they look at in your blood work. And I would imagine before you undergo a bone marrow biopsy, they're going to do some pretty good screening stuff. I think you're doing right to, work to improve your nutrition status, your health, and whatever you do along those lines, it's going to, be a positive for you. But my advice would just, stick with your primary care physicians. Obviously, the doctors that are coordinating the bone marrow biopsy or bone marrow donation are going to do the proper screening. And so that's, they have protocols in place that I think is going to be very beneficial for you.
Thanks. Excellent, doctor. And now we're going to bring in Maria. Hi, Maria.
Yes, thank you, Dr. Montgomery. I wanted to know your thoughts on chelation therapy for improving circulation and I guess lowering blood pressure, and your thoughts on, I usually take olive oil before this conference. I usually take a tablespoon of olive oil every day, and your thoughts on the oils and chelation therapy.
Chelation therapy is a 2B indication for treating patients with coronary disease and angina. So it's along with ECP therapy. We use a lot of ECP therapy, which is called external counterpulsation, which is another non-invasive way of treating coronary disease. And chelation therapy has data that makes it a 2B indication. So there is data supporting chelation in people with coronary disease and angina. And we don't use chelation, don't do chelation. So I don't have personal experience with it, but there is data supporting it. And then there's also data supporting chelation, removing certain toxins. And I think third-party payers will cover it in some situations, particularly with lead and some other toxic metals that can be effectively treated with chelation. But chelation, yeah, there's some benefit, and it's actually made it to the indications guidelines by the ACC/AHA. Oils, I don't advocate the use of extracted oils. Oils are problematic for a number of reasons. You want to consume whole foods, the whole fat foods. So if you instead of the olive oil, eat the olive, get a good source of a unpasteurized olive and consume that. Seeds, raw, in fact, I recommend all high fat foods be in their raw state. So I don't even recommend roasting seeds or roasting nuts or anything like that. I'd say they should be consumed raw and unsalted, raw, unseasoned, but it's consume those high fat foods in their natural state. When you extract an oil from its, plant of any source, it becomes rancid probably almost immediately, maybe due to the extracting process or due to the poor storage. And so there are a lot of problems with oils, even though you may have these first cold press oils. Now, some people advocate them. And again, that's why we are advocating doing the science and looking at the biochemistry, because maybe you can look at a group of people with raw plant-based diets with oil and raw plant-based diets without oil and measure the biochemistry and see what's going on. And so that may be the way to solve this question. But right now, we don't recommend it.
Thanks very much for that, Dr. Montgomery. And let's go ahead now to Isabel. Welcome, Isabel.
Hi, thank you. Doctor, I want to ask you a question regarding my father. Now, I'm living in New Zealand. My father's in France. So it's a bit difficult. But he's 84 years old and he's taking 3 medications. One is it's aspirin. One is for high blood pressure, and one is for prostate. Now, 5 weeks ago, approximately, he's out of the blue, his leg swollen. He had a strong pain, and he doesn't feel his toes. And he went to see the doctor, and the doctor said, "Oh, you must have a virus," and they gave him some antibiotics, but the antibiotics didn't do anything. So I just want to know, he suffered from his knees for many, many years. So he take anti-inflammatory for that.
Yeah. So, again, it's hard to make a diagnosis remotely, but a swollen leg with pain, you worry about with poor circulation or blood clot or something like that. If the antibiotic doesn't work, obviously you want to go back to the doctor and get follow-up assessment, because sometimes a tincture of time gives you, a lot of information. So if the swelling is not getting better, or if the pain is not getting better, then he may need to do some imaging studies, but certainly he wants to follow up with his physician, especially given that symptoms have not subsided with the antibiotics. And so, but close follow-up with his physician, I think, would be key. He also may benefit from imaging on that leg to see what's going on.
That makes a lot of sense. Thank you for that, doctor. And we're now going to go to, let's see, Vivian. Hi, Vivian. Hi, Vivian. Are you there? Oh, gosh. Vivian, I have you unmuted, but we are not hearing you at all. So I tell you what I'm going to do. I'm going to lower your hand, and if you can fix that on your end, that would be great. Come back into our list. Thanks. And so up next is, I'm going to ask Laura to unmute. Let's see if I can do that. Hi,
Can
Laura.
you hear me?
Yes,
Can
we
you hear me?
Yes.
Oh,
thank you.
what do you know? Oh, Dr. Montgomery, I want to move to Texas just because you're just so awesome. I want to live near you. So I had three questions. The vitamin C therapy, how much and what form of vitamin C therapy? The smoothies, what was in them and for how long? And if I'm a 67-year-old person, strong as an ox, plant-based diet, but I haven't been to a doctor in a long time. If I just want to make sure that my heart is doing everything it's supposed to be, what would be the optimal test that I should ask for?
Wow, those are great questions. Let's start with the vitamin C. It's probably the easiest. Many people use a buffered vitamin C. We use a liposomal formulation. It's really vitamin C in sort of fat, liposomal or fat envelopes. The absorption is probably a little bit better. You can get more in the system, especially these patients with acutely ill patients who probably have, gut inflammation. So anything that enhances absorption is beneficial. So the patient I mentioned was on a liposomal vitamin C. The smoothies, we had mostly greens in them. So it's mostly vegetables. We sometimes we'll use a date, or we may use an apple. So sometimes they have one fruit, but mostly have super greens in them. Some are just veggie fruity smoothies, or have beets or carrots in them. And so essentially so they have like a super green food that has lots of dehydrated broccoli, spinach, and kale, and there'll be a blue-green algae in it. So we want to get a lot of these super nutrients in high amounts in a form that they can absorb very rapidly, very easily. And so the amount of fruit we use just helps with the, palatability of it. They're sick in the hospital, and so there's some things that they're going through. So it makes it, if there's something to say, hey, I really like that, then great, they'll drink more of it. And I don't think the small amount of fruit in this situation can hurt them. We use foods that are procured locally for the most part. So that's what the smoothies are. Now, as far as the vitamin C, that in terms of the heart test, the interesting thing is this, to test your cardiovascular system, one thing is to look at your functional status. So you want to do that. So how long you can walk, far, or well you climb, that's a good simple test, and that's important. The other aspect, so that's the physiology. The other thing you want to look at is the biochemistry. And these don't have to be very fancy tests, but you want to get something that looks at inflammation. So you may get a C-reactive protein or a CBC. Look at your white count. You want your white count to be on the low side. Lots of people like to look at lipid levels or omega-3 ratio levels. Those are also helpful. If you could look at your lipid panels, look at LP(a), see if you don't have a high amount of these atherogenic. So these are the biochemical things that you want to look at to determine. So if physiologically you do well, your heart rate and blood pressure responds well to exercise, your resting heart rate, resting blood pressure are good, that's a good sign on the physiological side. And on the biochemical side, you want to look at things like lipids and inflammatory markers. So looking at those two gives you some insight at the macro and the micro level. And obviously, we come in, we do things that are more specific, that, endothelial function and so on. But if you do those basic things, plus you're eating a plant-based diet, you should be okay as long as you follow those.
Great. Thank you very much for that, Dr. Montgomery. Up next, we have Stephen V. Let's go ahead and unmute. Hi, Stephen.
Hi. I want to thank the moderator for the great job he does. I'd like to thank the doctor for the great presentation. I'm 67. I'm in very good health. Very good blood pressure, whole food, plant-based for a decade. But my homocysteine is around 12. And my C-reactive protein is around 2.2. And I'm just curious if you have any suggestions.
Yeah, and so it's a good point you make. Being whole food, plant-based, the homocysteine levels, sometimes, if your B12 level is low, you may supplement B12 or things like that. It could be something as simple as that. But also, microcirculation problems could be there. And that's why I like to tell people to look at their diet. How are you cooking your food? Where are you getting your food from? Because it's one thing to say you're whole food plant-based. We've seen lots of people come in a whole food plant-based, SOS, et cetera. But maybe they're microwaving most of their food or cooking most of their food. And maybe it's coming most from a supermarket that's getting from 2,000 miles away. It's set on the shelf for a while. And it's, GMO, et cetera, et cetera. Maybe it's coming from a can. Maybe they're preservatives and things like that. So, eating has become very tricky because, our food system is tricky. At least the food that we're exposed to is become abnormal. I'm sure they're going to have a lot of experts talking about, issues related to food procurement and the like. But you have to be careful. It's one thing to say, to be whole food plant-based, and we're all in a situation. But where does this come from? Are you getting adequate vitamin D levels? Are you getting adequate sunshine and fresh air? So what you want to do is you want to sort of inspect every aspect of what you're doing. The food you're consuming, how you're preparing it, how you're procuring it. Do you need supplements? Are there micronutrients that you're deficient in? If you see a functional medicine doctor, someone that can do a micronutrient test, either through SpectraCell or Geneva we use here in Houston. And so there may be micronutrient deficiencies. That could be, heavy metal overexposure, which again throws your biochemistry off a little, which may throw some of these things off. And so you just want to kind of, I think what you're doing is great, and congratulations on that. So you're probably more in a situation just fine tuning what you need to do.
Excellent. Excuse me. Excellent. Thank you very much. And next, we're going to bring up Denise. Hi, Denise. Welcome.
Hi, can you hear me?
Yes.
Great, thank you. That was such a fascinating presentation, and I can't wait for that study. I'm wondering if you might tell us when you think some findings will be completed. But my question is a follow-up actually to several things you've just said. I actually am a whole food plant-based educator out of Tucson, and sometimes I have students ask me this kind of question. Could I just buy the powdered greens and will that do it for me? And so, I would like to hear, what you have to say about that. And then kind of the powders of everything, the beet powders of this. I personally use amla powder, but I just would like to have a better understanding of how important it is to eat the fresh greens versus what we're going to buy from the grocery store that has been dehydrated and powdered. If you could share some of that, please.
Yeah, that's a great question. It's and I think it's that type of question that we're looking at, because let me just kind of step back and make a few comments, because I want to answer that question in the context of this the brief discussion. When we look at how we have to manipulate our foods, powders versus juices and smoothies, et cetera, we're doing that in a context where we have a population of people who are very sick. I mean, you may hear many of us go back and forth on smoothies, no smoothies, juices, no juices, et cetera, et cetera. And the argument one can make is that, how should we normally eat in the normal state? Maybe, if you go back to wherever, people like to talk about hunter-gatherers and all that stuff, people like to talk about cavemen and whatnot, but if you try to go back to some original state of how we should consume foods, I would say we should be consuming foods that are plant-based, that are found out in the woods, the forests, or wherever we find them. And we consume those foods as we find them. There are probably times when we're not eating, there are times when we're eating. And so there's probably a mixture of things that are going on. And so consumption of food is in the context of a lifestyle, that's rooted back somewhere long before, we were in modern civilization with, TVs and computers or whatever. Having said that, if you think about, okay, well, why powders or smoothies? Powders and smoothies are beneficial because they help make up for deficiencies. Many of us are not eating plant foods. Our GI systems are messed up. Maybe you have poor dentition, whatever the case is. And so you may have to drink a smoothie or powder. We're so deficient in certain foods that we have to drink high concentrated smoothies and powders to help us catch up. And so smoothies and powders and these things are important to the extent of our deficiencies and shortcomings and the need to catch up, if you will, or overcome a chronic. Somebody who's like the patient I presented, I can't go out and give them a salad or have them have regular food. They're sick. And so, yeah, they need smoothies and powders. Now, as far as the students are concerned, I'm thinking that they're not like these patients. And so I would like to say, yeah, if you have some, chronic issue, clinical issue, or chronic illness, and you want smoothies and powders to supplement what you're doing, I think that's beneficial. And maybe many of us need it because we live in this, world where our food is contaminated. So maybe we'll benefit from supplementation or a superfood enhancement. But to say to just have powders, I don't think that's ideal. I mean, personally, I wouldn't want to just consume smoothies and powders. I like to eat whole salads. And, in our shop, we make, gourmet wraps and salads and raw pizzas and things like that, the foods that I'm kind of familiar with. So I think you should consume foods in a variety of contexts and a variety of foods that way. I think the powders are beneficial. I tend to think of them as an adjunct to your diet, not the whole diet. It can be pretty boring just drinking a glass of powders and smoothies, unless they're saying, well, I want to eat junk food and then have powders. If you want to eat junk food and have powders, that doesn't work. My concept is, we have a saying, not a bite, not a drop, not a crumb. We're talking to patients about counseling on how well to eat. It's really the abstinence of the bad food that's most important, not just the eating of healthy foods. The least healthy eater in the world probably, lets a piece of spinach or broccoli slip past their tongue every now and then. But and nobody has, a few people, I should say, have trouble eating healthy food every now and then. It's just a total absence of the bad stuff. So if they're saying just the powders and as your healthy food and eat the junk food, I'll say no to that. Powders, beet powders, whatever, should be an adjunct to a normal, healthy plant-based diet, in my opinion.
Makes a lot of sense.
That answered the question.
Yeah, that certainly made a lot of sense. Thank you, doctor. And up next, we're going to bring out Stacy. Hi, Stacy. Welcome.
Hi, Dr. Montgomery.
Hi.
I have a question I wanted to ask you about. I'll tell you that I've been on a plant-based diet for 2 years. It's been a process. Originally, when I started, I was eating processed foods and things like that. And I learned, that I quickly had to get whole foods and go from there. So about 3 weeks ago, I've lost 65 pounds. I have probably 50 more to go. 3 weeks ago, I had a very stressful situation happen at work, and it caused my blood pressure to raise. Went to the doctor. They told me to go see a cardiologist. I went to see the cardiologist last week. He did a whole blood work. Most of my numbers were good. My lipid protein A came back as 196, and my C-reactive protein came back as 4.8. My LDL is about 99. My A1C is about 5.4. But I told him that I would like to do anything and everything else before statin. Of course, he suggested that I go on a statin. Once I told him that, he broached the question saying, well, because your lipid protein is high and your C-reactive protein is high, he's suggesting that I go on a statin. And how did I feel about that? Well, I told him how I feel about that. I just wanted to know, in your opinion, is there anything else I could try before I need to go on the statin, or to avoid the statin altogether?
But generally speaking, when I see patients come in, and of course you say you had an LDL cholesterol of 93, I want to make sure I heard you correctly there. Is that correct?
LDL is 99.
99, yeah. There's a way to calculate this atherosclerotic cardiac disease. You can calculate that using blood pressure, cholesterol, et cetera. I tend not to quickly prescribe statins, especially someone with LDL less than 100. The LP little a that's increased, the statins do not decrease lipoprotein little a. Yours is, I think, 100 and something, I think you said.
96, 196.
196, yeah. And so that won't be affected by a statin drug. Statins can decrease C-reactive protein. In the Jupiter trial, they show a 37% reduction, but that takes about 2 years, according to the Jupiter trial. And they had an increased report of diabetes in that population. Now, your hemoglobin A1C is 5.4, so you're not quite at the pre-diabetes yet, but another 2-3 of a point. What our studies showed, and this one I alluded to, that if you go on a raw plant-based diet, you see the reduction of not only cholesterol by over 20%, but you also see a reduction in the lipoprotein little a by 16% in just 4 weeks. We were actually the first to show reduction in lipoprotein little a in 4 weeks in a raw plant-based diet. And so you can follow that. And then you can follow, if you went on our website, montgomeryheart.com, you'll see a section called and I think Jackie, one of my people on this line, Jackie put the link to the food classification system. But if you eat from levels 0 to 4, 0 to 4B on our classification system, over 4 weeks, we see people's cholesterol comes down and LP little a comes down. Even a whole food plant-based diet that's not raw, Dr. Kim Williams and his group up in Chicago, shortly after we show reduction LP little a, they show reduction LP little a over about 5 or 6 weeks with just a plant-based diet by itself. So the anti-inflammatory results of a plant-based diet by itself can reduce C-reactive protein and can reduce lipoprotein little a and reduce cholesterol. So, I mean, that's the data. And so unless there's an acute reason to go on a statin, again, I'm not looking at your chart, but, you at least have the doctor give you like 6 weeks on a plant-based diet. And I think, you'll see that there's some improvement that she did put in there, montgomeryheart.com food classification system. So you'll see how we classify foods. And, the lower the number of the foods you eat, the more detox they are in that classification system. But that's something you can consider. You want to do a lifestyle change, a nutritional lifestyle change, whether or not you're on a statin. So it's something that I recommend to any and all of my patients in terms of getting their numbers right. Because these abnormal numbers are just small signals that something's imbalanced. And you don't necessarily get it in balance by making a number normal. You get it in balance by, making your nutrition normal or optimized.
Excellent. Thank you very much, Doctor. And we're going to move now to Janet D. Welcome, Janet.
Hi, thank you for taking my question. Hi, Doctor. I've been on first I was vegan and then I was on a whole food plant-based diet. I am. But I have low iron all the time. And of course, when you go to the doctor, they then tell you that you should start eating meat, which is not something I want to do. But it is something that some people in the community do struggle with. And I do eat a lot of greens. I do green smoothies. I have salads. I try to cook some greens as well. But it's something I'm struggling with. And then causing circulation problems, even though there's no diabetes or anything, but do have insulin sensitivity as well. So just wondering what your thoughts were on that. Thank you.
Yeah, thank you very much for that question. And the iron levels and things like that are pretty important. One thing I would say is this: first of all, look at the food you're consuming. Make sure you're getting quality greens and nutrients. And this is something I overlooked for a long time, when I was, teaching patients with plant-based nutrition. But there can be a big difference between consuming foods that are, sustainably grown, organically grown in your environment compared to what's at the supermarket. So make sure your greens are not just strictly from, and again, nothing against the supermarket. Supermarket's a great place. They allow distribution of foods and the like. and they do a great job. And many of us have grown up on it. But I think when you're trying to refine things and optimize things, then you may need to refine this. So that's one thing I would look at. The other thing I would say is consider consuming superfoods such as microgreens or sprouts. And so add those to your salads. Those have an increased amount of phytonutrients and minerals compared to the mature greens. And then foods like algae, we use the blue-green algae E3 Live. And then there are other super greens, spirulina. It's good. So you may want to use super greens. And then the sea vegetables. Dulse is one that we use I like to cut the dulse leaves and put them in the salads. Wakame is another sea vegetable. So sea vegetables, microgreens, micronutrients, sprouts, I think are excellent sources of enhanced phytonutrients and minerals that you may not be getting from the mature plant, especially the mature plant is coming from conventional sources that may not be from ideal soils and the like. So some people have to work a little extra hard to do that.
Thanks very much, Dr. Montgomery. And up next, we have Christopher C. Welcome, Christopher.
Yes, actors, it's Gwendolyn this time. I have a question in regards to my husband has been vegan for 25 years. They had no health problems until he had his amalgams removed. His total cholesterol is 121, triglyceride is 60, LDL is 62, lipoprotein is 32.3, omega-3 to 6 is ratio is 8.1. He had a calcium score done that was 0. And all his B vitamins are within normal range, and his vitamin D as well. However, he does have a low vitamin E, which is the gamma tocopherol, and he has a low iodine. And also, since then, he's had a PSA score of 6.2. No other health issues whatsoever. Do you have any advice?
PSA of 6.2?
That's correct.
Okay. Have you had it biopsied, or what stage are you at? I mean, where are you?
No, that we haven't had it biopsied as of yet.
Okay. Typically what urologists will do is they'll get like a 3-tessalon MRI to look at the prostate and make sure there are no metastases or the like. But again, disease states or health issues will manifest in different ways. And what I mean by that, so let's say if I get 1,000 people in a room and I fed them all, say, junk food, fast food restaurant X for breakfast, lunch, and dinner, I do that for a year. They would all get sick in different ways. And some of those 1,000 people have perfect cholesterols after eating junk food all the time. Some will have perfect BMIs, but then maybe the majority will have high BMIs and bad cholesterol, high blood pressure. But some will have, elevated cholesterol, blood pressure, all their cardiovascular numbers will be fine, but they may have depression or, some other mood disorder. And then some may have, perfect cardiovascular numbers, but then they may have early signs of cancer, et cetera. The point I'm making is that the way someone breaks down is different, and the genetics determine how you break down. The lifestyle determine that you break down. So your husband his cardiovascular numbers are good, the PSA is elevated. Could it be due to an infection in the prostate? That's possible. There be some other non-specific inflammation. That's possible. So there are a number of different mechanisms. So what should one do? As I tell my patients, you always want to examine where you are. So what's your nutritional status? Is it whole food, plant-based? If it's not, then you may want to make sure it's 100% plant-based. If it is plant-based, then you want to look at how you're preparing your foods. I tend to have people go on a raw diet, cleanse and detox. We also have them do time-restricted eating. Look at your phytonutrients. You may ask your doctor to get a SpectraCell test, look at phytonutrients. Make sure your vitamin D levels are adequate. Some people have vitamin D levels at a low normal range, when the vitamin D levels 80 or 90. So there are many different things that you can do, because we live in a polluted society. And even though many of us are working hard to do the right things, there are often little things that we're missing. And so we see an abnormality like that. It's not a time to be alarmed. Just step back and reassess where you are and find where the missing things are, where the holes are. tighten up the nutritional status, look at the micronutrients and see what supplements you need to take. Make sure your vitamin D levels up, things that enhance your immune system. Make sure you're sleeping well, the stress in your life. All these things are all important to kind of, work on that area. And of course, follow up with the urologist and get the follow-up. But there's usually the need to kind of jump and panic because, there are things that you can do to help, this situation overall.
Excellent. Thank you very, very much for that as well. And now we have a question coming in from Joe. Welcome, Joe. Oh, hang on. Let me unmute you. And why am I having an issue? Bear with us here. Joe, I'm going to try and unmute you again. I'm not sure what's happening there. And one more time. Joe, that's just the strangest thing. I don't know what's happening. I'm trying to unmute you and it's just not clicking through. Joe, do me a favor and I'm going to lower your hand, and then if you can raise your hand and come back in. And in the meantime, I will ask, I've got a question of my own for you, Dr. Montgomery, while Joe does that. Mm-hmm. Just in case anybody has missed this along the way, how do dairy products like milk and yogurt and cheese affect our health? And just what can you touch on with regards to all of those?
Wow. These are inflammatory-triggering foods. I mean, we see certainly with dairy and of course, yogurt having dairy in it, eggs. Our patients have lots of inflammation. Some people refer to them as mucus-forming foods. Many people have lots of mucus or inflammation in the sinus tracts, but patients with cardiovascular disease and hyperlipidemia do very poorly. And we've seen a lot of vegetarians over the years who are consuming dairy, and it predisposes to cardiovascular disease as much as it does any other illnesses such as cancer, like prostate cancer in some cases, men, and other conditions. So these are pro-inflammatory foods, and as I showed you in some of the slides, mechanistically, they trigger inflammatory reaction, which plays hand in hand with increasing oxidative stress. And, it affects you at the biochemical level and leads to chronic degeneration of the cellular structures systemically.
Got it. Thank you very much for that. Again, I'm at the point now where I don't see any extra hands. I do want to remind everybody we've got a few more minutes before our next lecture, and what a great opportunity to be here with Dr. Baxter Montgomery. So anybody else wants to raise their hand, please do bring in a question for him. He's happy to answer them. In the meantime, I was going to say I've got more, but I see Stephanie is back. Let's go ahead and bring her in. Hi, Stephanie.
Hey, well, while you're here, do you have any advice for someone who has tachycardia that seems to be like worsened and triggered by any type of food that they eat almost, but especially obviously by the bad guys like sugar, salt, makes my heart rhythm go crazy, like up to the 180s and stuff like that. But even if I just eat, like plant-based diet, good foods, it still, triggers reactions and stuff like that. Any advice?
Yeah. So you are probably very sensitive. So again, you're probably at a very imbalanced situation. So people with tachycardia is imbalanced. So you want to consume, certainly more bitter foods if salt and sugars trigger it. And, everybody's situation with sugar is different. And I know there's a previous discussion in terms of sugars and forms of any form of fruits. And, Brian Clemens talks about how hybridized our fruits are. And you walk in the supermarket, it's hard to find grapes with seeds in them and things. And, you have organic watermelon without seeds. So I think, all of our food is, much of our food is hybridized, a big problem. And fruits may suffer to a greater extent to that because of people's sugar addiction. So, you may want to go on a regimen where you're doing raw plant foods and you're just removing the sweets of any kind or sugars, even the so-called healthy fruit sugars from your regimen. So, it could be that, especially if you know that you had a quote unquote sweet tooth, or if you consumed a lot of processed salty foods, your body just may need to detox from that. Make sure you're hydrated. I recommend people consume a liter or two of water in the first thing in the morning, ideally. But better hydration is going to improve your overall condition in terms of the heart. But, consume foods like, cucumbers, tomatoes are okay. Any hydrating foods that are low glycemic index, in addition to, say, your salads and the like, and give yourself, say, 3 to 4 weeks of that. And I think this tachycardia, can probably be suppressed. If not, obviously see your doctor, get a monitor. It could be some arrhythmia or something like that. So make sure you get it checked out one way or the other.
Thanks, Dr. Montgomery. And looks like Stacy is back. Let's bring you in. Hi, Stacy.
Hi, Dr. Montgomery, I just wanted to ask you, when I asked my question before, you said that I would benefit from a raw food, plant-based diet for at least 6 weeks. And I just wanted to know which one of your programs would help me with that.
I think Jackie had put in our site in the chat. It's online.montgomeryheart.com/lifestyle. Do you see that in the chat?
Yeah, I see it, but there are like 4 different courses. There's one.
Go to the healthy lifestyle.
Oh, I see. Okay.
Should be healthy lifestyle series. The healthy lifestyle, and just to kind of give you a breakdown of that, our healthy lifestyles course, it's really a prime course where it's a 1-year live group coaching. And it starts off with a detox series. So at the beginning of the course, when you schedule to start, and we have certain scheduled dates to start, although you can start anytime in between that. But if you start, say, one of the scheduled dates, the beginning of a course would be 5 sessions over 4 weeks, where our team is talking to you and coaching you through a raw detox. So let's say you decide to go on raw foods. We can talk you through that. And then you have information in terms of how to prepare the foods, where to get the foods, et cetera. And there's a lot of resources in terms of recipes, food demo videos, and the like. We talk about supplements that are beneficial, not beneficial. Then we're going to talk about your individual, situation. Individual questions are addressed. My staff have access to me. Of course, I'll make cameo appearances on these courses. And then you have access to everything downline. So you may look at like a rebuild program, which is an on-demand course, and it has videos and the like. But as an HLS member, you have access to all of that, which has more recipes. And then you're part of our community, where there's more interaction, there's support groups. So that membership puts you into a community. You get specialized coaching plus access to lots of other resources. And so, that's something that I think would benefit you quite well.
That's great, Doctor. Thank you very much for that. And good luck to Stacy. And so now we're going to bring in Shashi. Welcome.
Dr. Montgomery, I want to know what to do for someone who has been a vegan SOS follower for over a year and having challenges with neurodegenerative disease. And there is extreme weakness, even in having as much as totally fresh, not even so much frozen, totally fresh vegan diet. What particular things will be beneficial to stress on to help the brain gain what it needs?
Yeah, great question. Great question. Well, generally speaking, I can't give too many specifics without detailed information, but when you have specific issues, brain foods and the like, make sure you're getting adequate fats in the diet. Oftentimes people on a vegan diet, SOS, maybe on low-fat diets, or if the fats you're consuming are not cooked. So I make sure people are getting adequate fats, seeds, preferably over nuts. I'm okay with avocados. But all these foods should be raw. You also want to make sure you're getting super nutrients, make sure your vitamin D levels are high, super greens. There's certain mushrooms that can be beneficial in people with neurological disorders and the like. But make sure that the food is being prepared in a way that is fresh. And I even recommend some of my patients who have neurodegenerative disease come in and go on raw diets. for a certain period of time. That's just to make sure that the food is not contaminated in any substances. And then you want to look at, micronutrients. So if you have a good functional medicine doctor that can measure micronutrients, make sure they're not, toxic chemicals in your blood that may need to be chelated or removed from the system. So there are a number of other things that you want to look at from the standpoint of a neurodegenerative disease or anything else, because there are oftentimes these hidden little troublemakers that we need to look at and address that needs to be evaluated. So I think a good whole food plant-based diet is a good foundation. Sometimes that has to be tweaked. And also you want to look at micronutrients or phytonutrients that may be deficient or toxins that may be in excess that may be contributing to the problem.
Thanks very much for that, Dr. Montgomery. Up next, we have Janet. Welcome, Janet.
Hi there. I just had another question. So I had talked about being on a whole food plant-based diet, but I've been checked for my blood sugar. It seems to be okay, but I seem to be very insulin sensitive. And I know I do try to reduce, like you were talking about fruit, I try to limit my fruit intake, but it just seems that like the other woman was saying, I feel like my blood sugar's off after I eat, like the heart is racing a bit, and have circulatory issues. But whenever I do the blood work, nothing really shows up. So just wondering what I can do. Like they do recommend eating beans, but beans don't seem to really, they seem to spike my blood sugar and those kind of things. So just at a loss.
So give me an idea of what you eat. What's a typical breakfast, lunch, or dinner?
Yes. Okay. So in the morning, I do a smoothie. I do put some flaxseed in it. I put greens in it. I just do that for the iron deficiency kind of thing. I put a bit of berries in it, and I might put some amla powder and cinnamon. But then I'm pretty hungry after. So then for lunch, I do a salad. I will add avocado to it, like cucumbers, carrots, whatever I have, peppers. I might put some hemp seeds on it or something. And for dinner, I maybe a stir fry with a quinoa or something like that.
You have any oil in the stir fry?
No, I'm trying to avoid the oils. Yeah.
Okay.
Because I'm not digesting them very well. So.
Gotcha. So, I mean, it sounds like you're doing pretty well for the most part. What I would recommend doing is going to a diet that's 100% raw. And the reason I like doing that with patients is that, so in the morning, instead of the smoothie, maybe a cold pressed juice with carrots and celery and things like that, or beets. Then you may eat a large green salad, and maybe 2 large green salads. I like the idea of the sprouts and those types of things. I get rid of all the cooked foods for a certain period of time, maybe 4 to 6 weeks, because that allows your body to heal. The other thing I would recommend doing is do a time restricted eating pattern from say 11 to 4, 11 to 5 p.m. Try something like that. Because increasing the fasting window throughout the day allows the body to heal. So whatever that biochemical imbalance is, may allow the body to correct itself more effectively.
Excellent. Thank you very much, Doctor. And let's go ahead now to, I'm not sure if I'm pronouncing this correctly, Aaron or Aaron?
Yes. Can you hear me, Doctor?
Yes, I can hear you.
Hi. So I have a general question regarding, artery disease and being vegan. I diagnosed, I did a CAT scan a few years ago, about 4 or 5 years ago, and they found a blockage of about 50% in my arteries, and I changed my lifestyle, become vegan and change, do more activity and everything. And and how would you recommend to check if, my lifestyle change, made my situation better? I understood that, CAT scan have a lot of radiation that maybe it's not a good practice to do so periodically. I understood that there are some other tests in place like CMIT, not sure if you're familiar with, which call carotid intima media thickness test that, it's like an ultrasound that does not have radiation. Would you recommend to do it just to check, if the situation become better or worse, or did not change? How would you recommend, a person to know if, the change of the lifestyle made the situation better or not?
That's an excellent question. So in essence, you had a 50% lesion 4 or 5 years ago, you changed your lifestyle, how do you do follow-up? You don't want to get a repeat CT angiogram, you want to avoid the radiation. There are a few tests that I would recommend. I would still the basic things I like. So, is your functional status better? How far do you run? How far do you walk? Can you climb hills? So make sure your physiology from a clinical standpoint, symptomatology is improved. And so it sounds like that's the case, just listening to you. Basic blood work, I think, is reasonable. Look at your cholesterol, look at inflammatory markers like C-reactive protein, lipoprotein A, those types of things. And if those are good, that's fine. There's some special tests that we do in our clinic that I think that's, available in most places in the US. One is a test called ultrasensitive troponin, an ultrasensitive troponin. I'm going to say that again, ultrasensitive troponin. I know Quest Diagnostic does it because, we have Quest in our lab and they're kind of all over the country. The other test is a special test, and the lab is out of, I think, in Irvine, California, called a pulse test. That's capital PULS. Protein unstable lignan signature, something like that's what it stands for. But you can Google it, PULS test. And we use that. That looks at a number of biomarkers, most of which are inflammatory, that has a good correlation with the amount of vascular inflammation or coronary stenosis. And so if your PULS test, a pulse score, is low or within the expected range, then that's a good sign. Because it's used to predict your chance of a cardiac event in 5 years. And actually, I'm going to type that in the chat real quick. It's PULS. That's the pulse score. So that you look up, in the ultrasensitive troponin is one. I think Jackie Williams put that in there. So those are 2 extra tests in addition to the usual things you can get that I think will give you some good information.
Thank you so much, Doctor.
Thank you.
Thank you indeed, Dr. Montgomery. And thanks to Jackie for all of her support along the way as well. And we just so appreciate this. It's time to get into our evening time lectures, evening here at least where we are on the East Coast. And just want to thank you again, not only for coming back year after year, but just this tremendous presentation that you did today and being so gracious with your Q&A. I want to thank you. I know I'm not the only one that wants to thank you. We're going to unmute our entire audience. Everybody, what do you want to say to Dr. Montgomery?
Oh my God.